Welcome, everyone. My name is Emily Becerra, and I'll be moderating today's Modern Healthcare Custom webinar, Solving for Rural Health Disparities. During this webinar, we'll discuss how rural healthcare providers are striving to provide high-quality care amid disparities in their populations, as well as innovative solutions to these disparities. Before we get started, we'd like to thank our sponsors. AARP is the nation's largest nonprofit, nonpartisan organization dedicated to empowering people 50 plus to choose how they live as they age. With a nationwide presence and nearly 38 million members, AARP strengthens communities and advocates for health security and financial stability. Community Hospital Corporation owns, manages, and consults with hospitals through 3 distinct organizations: CHC Hospitals, CHC Consulting, and CHC Continued Care, which share a common purpose to guide, support, and enhance the mission of community hospitals and healthcare providers. Nuance offers community and rural hospitals speech recognition, real-time intelligence, and metric solutions that provide a more natural, accurate, and efficient way to capture the complete patient story. Nuance has built their business around the idea of first time right, ensuring healthcare documentation is the best it can be. A couple of housekeeping notes before we get started. We want this webinar to be an interactive experience for you. You are encouraged to ask questions using the questions pane in your GoToWebinar attendee panel. Our speakers will try to address as many of your questions as they have time for. You can also download resources from our sponsors in the handouts pane of your attendee panel. Should you need any assistance during the webinar, please don't hesitate to contact us via the questions pane in your attendee panel. I am pleased to introduce our esteemed panel of healthcare experts for today's webinar. Bob Steffen is AARP's Vice President of Caregiving and Health Programs and serves as AARP's lead for family caregiving. In these roles, he leads the strategy and execution of AARP's enterprise-wide efforts to help 50-plus Americans live independently as they age, while supporting the 40 million family caregivers who so often make this possible. Jim Kendrick is the President and Chief Executive Officer for CHC, a national leader in advancing community-owned hospitals. Jim gained more than 20 years of experience as an executive for not-for-profit and for-profit hospitals and healthcare systems before joining CHC to lead the organization. Dr. Robert Budman is the Chief Medical Information Officer at Nuance Healthcare. He is board certified in family medicine and informatics. He focuses on efficiency, safety, and quality initiatives with global experience in multi-EHR and service line care delivery. His work involves implementation, workflow adoption, and optimization. Dr. Budman has earned multiple clinical awards and speaks extensively on healthcare IT. And now I'll hand it off to our panelists to offer a brief look into their experiences and insights over the last few weeks. Bob, let's start with you.
Thank you, Emily. I guess if we go to my first slide after this one, I know that Emily gave a little bit of an intro to ARP. I'll give a little bit more in terms of, while you may be familiar with the name, why we're here, might be a question that you're having. And so, as a large nonprofit, health security is part of our social mission. And we focused in that area primarily on family caregivers, those who are providing a great deal of care for those 50 and above older adults. And so that really fits into this disparities discussion from a couple perspectives. One, we like to look at just the entire picture, that if you're looking at disparities for older adults, we also want to look at the disparities that are affecting those that are caring for them. But also, one of the things we look at is that these family members, these friends are also, they're really a member of the care team, an informal member of the provider care team. If we go to my next slide, probably for many of you on the line right now, this is not new, but when we look at the disparity for older adults, we know that roughly 20% of the 65 plus live in rural communities, and they're more likely to be uninsured. They're going to live alone, be closer to the poverty level. They're going to be more likely to suffer chronic conditions and physical disabilities, and they're certainly going to have less access to healthcare services and telemedicine. If we go to the next page, I mentioned the family caregivers, and we like to say, while it's not the entire part of the disparities discussion, but we think that it's very important as an organization to look at family caregivers in the context of that disparities discussion. And across the country, there are 48 million people over the age of 18 who are providing care to someone, an older adult typically. I noticed that in my bio, I neglected to update the new data just came out with a few months ago, but we're up to 48 million family caregivers. That's a significant increase of over the last 5 years. And these are people who are driving their loved ones to medical appointments. They're the medical scheduler, trying to coordinate everything, the cook, the dietitian, they're doing the shopping. They're the care manager, the advocate for their loved one in the facility, and they're often the individual who's asked to do complex medical tasks at home. And they do what they do because they're a daughter or a son, their family. They're a friend, they're a neighbor. And but by doing that, they're sacrificing their time, money, and their health. And that is even more so in rural communities. So when you look at those 48 million overall who are providing these types of this type of care, 15 million of those across the country are caring for someone in rural communities. And they're more likely there to be spending much more of their time providing the care. Spending much more time in their car doing the traveling. They're less secure financially. They're less likely to have insurance, and they're less healthy. They're more likely to report that their caregiving burdens are causing them to their health to suffer. All in comparison to those in non-rural areas. So when we talk about disparities, it's hitting both the caregiver, but also the care recipient, obviously. If we go to the next page. And Emily, you mentioned what's happened in the last few weeks. I think what we've seen, at least looking at it from the perspective of the family caregivers, those living in rural areas, is that what's happening during the pandemic has really exposed a lot of the issues that are out there. We know that there's been a delay in terms of getting care. The inability to get in some instances to receive care in the hospital setting, have your loved ones with you. And from a family caregiver standpoint, we've seen that those caregivers are more alone. They're being asked to do more. They're more isolated. And relative to those in other markets, they're less able to take advantage of telehealth, or technology rather, both for telehealth, but also for their own working situation. We go to the next page. So how do family caregivers fit into the disparity discussion? So from a disparities point of view, what we found from a positive standpoint is if you support family caregivers, you bring them into the experience, you'll find that you end up with improved patient coordination, better adherence, particularly on medication, fewer discharge delays, and there are multiple studies that show that supporting family caregivers, educating them in terms of what they need to be doing once the patient leaves home, leads to fewer readmissions. So there's definite positives for improving the health of the patient, but there are also outcomes that show that it's better for the family caregiver if they're better supported. We find that they have less stress. They may be more encouraged to take their own health seriously. And there are studies that show that their depression levels, which are typically higher in family caregivers relative to non-family caregivers, depression tends to be higher, but if you support them through that process, you can reduce that depression, so helping the overall healthcare of those involved. And there's a competitive, maybe not necessarily a disparities point of view, but we also know we talk to enough families around the country and we say, okay, if you had a choice between, you knew that you were being supported, being asked about, you were given the information you needed from one provider, and in another you didn't get that, what would that do for you? And we hear almost all the time, well, that's where I want to go to the organization that's going to support me and my loved one because I feel like they're getting better care. And so from a competitive point of view, we think there's something there for rural providers as well. Go to the next page. So what can hospitals and providers do to better support family caregivers? These are things that we've seen be successful. Number one, it really, I think if you had one place to start, it would be at discharge, whether that's outpatient or inpatient, and providing information and help with the family caregivers, giving them the, this is what you need to expect. This is what you need to do. If you're going to have to do something at home, let me just show you, what that's going to be like, so that the family caregiver is confident. They know what to look for. They can better care for their loved one and really avoid those readmissions. Connecting them to the resources that are in the community. Quite often, they're already through the ADRCs, the AAAs that are out there in the communities, those resources, but family caregivers might not know where they are. And we know that when you look at, if you ask families, what's your number one trusted source for information? Well, number one, they're going to say my family. Number two, they're going to say my medical provider. So being able to connect them to the resources that are out there, and then also connecting them to support groups and support that might be out there in the community. So I'll close with one final slide. And that's from the ARP perspective. So, why are we here and what are the things that we're doing to support that? We're committed to delivering the best resources possible to everyone freely. And that includes workbooks to help family caregivers prepare for their role. It's also helping employers understand what they can better do to support the working caregivers that they have in their employment. Videos that we've created with leading nursing institutions that give family members a how-to on complex care that they have to do at home. And convenings where we bring folks together to look at what are the best, some of the promising practices from a rural standpoint, but also specifically to hospitals and what they're doing. And then finally, later this year, we're going to be releasing a toolkit that we've been building with rural hospitals and rural family caregivers that makes getting information out there easy for the healthcare professionals, so it's not going to take up too much of their time, but also easy to access in the ways that the rural family caregivers need to access things. So, for us, we're committed to making sure that family caregivers are supported and that we can make it as easy as possible for rural providers to do that. And I know I've included the email address up there because if anyone's interested in actually learning more or actually just getting some of the resources we have, we will send them to you. So with that, Emily, I'll turn it back over to you.
Wonderful. Thank you so much. Jim, would you like to provide your perspectives?
Yes, thank you. I'll start, as you're loading up the slides, give you a quick overview of the company. We've been around for 25 years. And ironically, when we were formed 25 years ago, it was for many of the same challenges that are being faced today. 13 healthcare organizations came together to form this company for small rural community hospitals to have an option. Again, not unlike today, many hospitals were facing closure, having to sell, and in order to face those challenges, there were very few places for them to turn. So this company was formed to help rural healthcare and rural hospitals survive and be able to sustain caregiving in their market. So that was our foundation. Our foundation hasn't changed. As we move forward, we've just found more and more ways that we could try to help organizations move forward in that space. Today, we own or manage 26 hospitals in 12 states. We're doing consulting work in another 27 states. So we're touching 39 states actively right now. And that gives us a good perspective because we're literally touching hospitals across the country in a variety of different environments. If you'll go to my next slide, I'll use a couple of points for dialogue. We've all heard this, how many rural hospitals have closed, and, you hear that data all the time, but just recap it from a perspective, 128 hospitals have closed since 2010, closed or filed bankruptcy. That number for this calendar year, for literally the first 6.5 months of the year, there have been over 40 bankruptcies or closures of hospitals, not rural hospitals. But 2/3 of those hospitals were rural hospitals. So the issue, if you look back over the past 10 years, that's averaging 10. Again, we've had over 40 this year alone that are in that space. So it is a crisis. It is something that needs to be very top of mind when we're looking at how we're going to provide care across the country. And a couple of the data points that are in this slide, 57 million Americans still depend on that local rural hospital to provide the care that they get. And it's also a tremendous impact on the local economy. People don't realize when they lose their rural hospital, it may be a small access hospital, but the number of employees that are meeting their needs from that work at that organization and the families that are covered and the services that are covered, it has a crippling effect when a community loses its hospital. So it's really something that we are extremely concerned about, making sure people keep it as top of mind awareness. The pandemic that we've been facing is just all the more risk that these rural hospitals are facing. Across the nation, not everyone's done it the same way, but canceling of elective procedures across the nation started out almost as a blanket approach. Now, luckily, we've gone back and we've morphed that so that many places it's only the major metropolitan counties or cities. But across the country, at many times, you had rural hospitals that were not able to do any elective procedures, but they may have only seen 1 or 2 COVID cases. So we have to make sure we have a voice, because that voice has to be carried forward in a way that we don't take a one-size-fits-all approach to how we move things forward with trying to sustain healthcare in these rural markets. I won't go into too much detail. I think there's a case study here on the bottom that can be looked up, but we closed a transaction to save a rural hospital in Huntsville, Texas, on February 28th. And we got that transaction done on February 28th. And what we did is we went out and formed a partnership with the district in the community. And that hospital was actually having to go through bankruptcy from its former operator. But we went in and formed a partnership with the district to buy it out of bankruptcy. And it's open and doing well and positively cash flowing. But literally, had that transaction not got completed, that hospital would be closed today. If we hadn't got it closed in February, we went into COVID. The dynamics of how transactions get closed, that hospital would have its doors shut today. And it's got over 100 patients that are getting care in that community right now. It's a community that has a university. It's a community that has a large number of employers. So the next closest major hospital would be about 45 minutes away. So again, it's extremely important that we focus on the necessity of making sure that these rural hospitals, these rural communities continue to have that service to provide. Let's advance the next slide. Now, again, this is just kind of a thought-provoking process, but when we go into a community, we go into a hospital, we start looking at what they're doing and how are they addressing the needs of their community? Who are they serving? What services are being provided? Can they afford to provide all the services they're providing? And one of the dangers of a lot of hospitals is they want to be all things to all people, but in all reality, the ability to afford that is not there. So you have to make sure you're providing the right services that you can. Another key component is, it doesn't matter how much work you're doing and how much bills you're sending out the door, but what can you actually get compensated for? And are you being fairly compensated? And that's one of the challenges of some of the rural hospitals, because of the complexity of the business that we're in today with healthcare. There's so many nuances associated with what you have to do to get properly compensated. And sometimes these rural hospitals don't have the depth of talent, and it's not a negative comment, it's just they don't have the number of resources. They're a small facility, so they have one person doing all managed care, all billing, all of those things are under their responsibility. So they don't have access to the latest technology, the latest data, and it drives their ability to actually get fairly compensated for the work that they do. Again, I'm not going to read the slide to you, but again, the short version of it is this: it's basic blocking and tackling, and that is, what can the hospital afford to do? What is the hospital doing? Is it managing its expenses appropriately in line with what it should be from an industry perspective? Is it maximizing all of the federal dollars that can come to it through a variety of ways? Is it doing things appropriate on its cost report to make sure that they're getting compensated appropriately there? And if it can't survive on its own, what collaboration models are they exploring? How are they looking to partner? What are they wanting to look like in the new model? Because an independent freestanding hospital, it's very, very difficult for them to have the resources necessary to be successful and sustain the provision of care in their community. Let's go to the next slide. This is just an example. There was $175 billion approved for CARES Act funding. Now, that funding, I can tell you that the number I told you earlier, over 40 hospitals filing bankruptcy this calendar year, that number would be astronomically higher had the CARES Act money not gone through. So you have all these hospitals that receive this money in a variety of formats. There's advanced Medicare payments, but those are advanced Medicare payments that are going to be recouped out of future billings. There were things like payroll protection. But again, if you're going to get payroll protection, you have to properly document and show that you use those funds appropriately, so that loan is turned into a forgiveness or to a grant. Again, this is just a tool we put out on our website for anyone to access, but this is a basic level. But you drill into it. The point being with something like this is just to say there are so much complexity that is associated with the ability to get properly reimbursed, and also to make sure that you are able to keep the dollars that you receive. Let's go ahead and go to the next slide. Again, I won't read these to you. These are just 3 examples. Since the pandemic has struck, there has literally been a 50% surge in telemedicine across the country. Telemedicine is a good resource for rural healthcare communities. It provides them a level of care that they otherwise may not be able to have. And the regulations, the reimbursement, the bureaucracy behind it has actually had the ability to get loosened because of this pandemic. And I think we are touching far more lives because of the willingness to loosen up some of those restrictions. Again, you have to make sure that it's done properly and it's done well. But if you have the right platform, if you're working with the right organizations that have done this and know how to do this, you can bring that care to the patient in a more safe environment so that they don't necessarily have to travel. And in many cases, we talk about disparity, and I'll cover that a little bit more later, I think, but there are many people in these communities that don't have the ability to hop in a car and drive 45 minutes for care. They don't have the gas money to get there. So things of that nature are essential. Finding ways to get care to the patient. Telemedicine, I think, is going to continue to grow. We need to continue to focus on being a strong message to make sure that the government structure for reimbursement continues to be flexible and allow this fast growing area of growth opportunity to bring care to these rural communities. Let's go to the next slide. Again, I think we're just trying to give some examples of some of the innovation. In order for small rural hospitals to survive, they've got to be innovative. They've got to find unique ways to grow revenue, to control expenses, to partner, to align. But one of the big crises that you saw through this early stages of this pandemic was the fact that people could not get the personal protective equipment, the PPE that they needed to be able to provide care. They were fearful of having the supplies that they needed to be able to make it work. That's part of being part of a large GPO. That's one of the things that we work with our hospitals. We're actually part of a very large GPO that just from our organization alone, we're probably running around $600 million worth of supply spend. So when you're buying at those levels, or you're buying through a larger organization, which in our case is Health Trust. So Health Trust is such a large organization. It's owned by these major healthcare providers, but they don't necessarily go out and sign up as a critical access hospital in rural Utah. But that same critical access hospital could sign up through our company. They're still getting the Health Trust pricing because we aggregate the purchasing power of all of the organizations that come through us. Again, that goes back to the $600 million number. But that gives that small rural hospital the ability to buy at the same price that the large organizations are buying at, because they're buying under that aggregate purchasing power. The reason that is relevant is because if you look at the expenses of hospitals, both rural and metropolitan, its supplies are the second largest expense. So when you look at buying under the appropriate channels, the right GPO, you can save a minimum of 10% on your spend. Well, if you're a small rural hospital and you have a $5 million spend, that's guarantee on a 10% savings, $500,000. Many of these organizations don't have much more than a $500,000 bottom line anyway. So it's a very important issue. I think that this was using more of a specific example of the innovation side of things. Titus Regional Medical Center in Mount Pleasant, Texas, was having difficulty getting some PPE. We were working with a variety of organizations to try to bring things in, but there was a local chocolate factory that said, you know what, we think we can convert what we're doing and we can make face shields. Well, you know what, we looked at it. Turned out that the product that they were creating was just as good and just as a quality of a product. And so they started buying face shields from a local chocolate factory. So, I mean, just again, that's just a unique idea about innovation and the ability to make things work. Let's advance to the next slide. And, I spoke to this a little bit earlier, but, when rural hospitals are facing challenges and deciding, they're worried about payroll, they're worried about, next month, how are things going to go? This is not an organization that's worried about, does it have a margin big enough? Does it have distributions well enough? These are small community hospitals that are worrying about caring for the loved ones they have in their community. When they're doing that, many times they have to look for other organizations that they're going to work with. How do they align? And that affiliation, that alignment, is essential to the success, both in a financial alignment, both in a clinical affiliations, how you're going to be structured from a management perspective. Are you going to work with someone where they're going to become a corporate member? Is it going to be a complete acquisition? Again, you have to protect yourself as these decisions are considered, because as you move forward, even good intended organizations that acquire some of these rural hospitals, what the burden then becomes later is what allocation of expense gets pushed back down to the rural hospital. So the rural hospital is struggling, it gets bought. Well, after it gets bought by a well-intended organization that bought it because they want to help, but they want to make things work. Most people aren't buying rural hospitals because they want to, oh, this is a great margin opportunity for us. They're buying them for reasons, hopefully in the not-for-profit place, the mission-driven space. And as they're doing it, though, they still have a methodology that says, look, because of these resources we're providing, we have to allocate expense back to the hospitals. And sometimes those allocation expenses are more than the hospital can stand. So now the system that bought it sees the hospital as a negative, but again, that negative is largely driven by the allocation that's pushed down on the hospital. Again, just some interesting thoughts for provoking dialogue. Let's go to the next slide. I think I touched on a little bit earlier, but innovation, finding ways to make things work. I mean, I could list 30 different examples of how things are done completely different today. But how hospitals work in the past can't be the way hospitals work in the future. Specifically in rural healthcare, you're going to have to see more things focused on telemedicine. You're going to have to see things focused on the delivery model and trying to make that delivery model as cost effective as possible. And at the same time, working to make sure that the hospitals are fairly compensated, that they're getting the revenue that they need to get for the services they're provided. And many times that's one of the main areas that we find is not happening. An organization may be providing the service, but because of a litany of bureaucracy issues, they're not getting fairly compensated for that care. So that's essential. Finding the right relationships, partnerships, and how you do put those models together is essential. I believe that's my last slide, and I think I'm also at a time I need to be handing it over. All right, thank you very much.
Wonderful, thank you so much, Jim. And we'll move on to Dr. Budman. Can you please provide your insights?
Yeah, thanks very much. As soon as my slides come up, I do want to add that I've worked in some of the smallest and most remote communities from Oregon to Vermont, and I've actually worked in the Australian outback where people had to drive over 3 hours to come see the doctor. And the hospitals were tiny, if staffed at all. Next slide, please. And I also have the luxury of having Bob and Jim going before me, so they've already spoken about some of these rural health disparities in current state of rural health, like closed hospitals, disbursement of people and their access to health care, poor communities, elderly communities, uninsured communities, and the fact that many hospitals without bailouts or partnerships may close. So let's go to the next slide. So the challenges are, as discussed with COVID-19 and threatened revenue, is this lack of mobility and remote options. How do we get clinicians out there, acquire them and retain them? And a lot of physicians are looking for these new technology investments. How do you do that on a limited budget? Let's go to the next slide. Is what sort of things is Nuance doing to address these challenges? Well, the first one is cloud-based solutions, and there's two reasons why these are so important. Often these small hospitals are lucky if they have one part-time IT person. So how are they going to sustain a highly innovative technology program? That's one. Oh, thank you. And number two is, nope, that slide, thank you. And number two of that cloud-based solution is it allows the expertise as we host it in a secure environment to provide the highest quality and newest technologies through the cloud. Now, the interesting thing about telehealth that both Bob and Jim mentioned is now in the remote areas where people can't come in, is if they have a phone or an iPad or even an older computer, the ability to either call in or do a video visit if it's a checkup for medications or how they're doing and how's their blood pressure and things like that. But the interesting thing that we've seen now in this boom of telehealth is the physicians are doing this telehealth. They hang up the phone and they're like, oh, I need to write this out all down. How am I going to remember everything I just said on the visit? Next slide, please. So in this age of telehealth, where there's now this booming business of doing things by phone or iPad or whatever mobile device that has video capabilities, is what can I do to supercharge that doctor-patient relationship through this new, what we've heard many times now, the new normal or the new options that are available through innovative technologies. Next. So one that we have is called Dragon Medical One. This is cloud-based speech recognition. It's highly accurate. It doesn't need to be trained. It learns on the fly. It's very easy to use. It's amazingly secure on Microsoft Azure, this high trust and secure that we all hear about all the time. It has on-demand analytics, so you can see how well you're performing. And it is the foundation for the future, which means not am I just going to be speaking to the phone and it's going to recognize my voice and turn it into text, but it'll be able to listen to multiple people through the phone without having to do anything beyond that, and it turning into a full and complete medical note. Next slide. It can be done through a smartphone, iPhone and Android. This is a depiction of what we call PowerMic Mobile. It basically turns your phone into a microphone, and you can see it has functions on the screen that allows you to record your voice and do your notes remotely, so that it makes your physicians more efficient. They're not typing, they're not spending as much time doing administrative tasks in the EHR, and they're getting their work done much faster so they can spend more time with the patient. Next slide, please. That is going to transform into what says here, which is ambient clinical intelligence, or what we now call DAX, which is the digital ambient experience, which allows the entire doctor-patient not the relationship, but the doctor-patient visit to be completely hands-free, where the physician is talking to the patient, perhaps the caretakers in the room, and differentiating their voices. If it's children, if it's elderly, if there's a nurse in the room as well, and it will completely differentiate the voices, and in the end, transcribe a complete end-to-end note. So at the end of the session, the physician doesn't have to try to remember and then go document it, type it, or use some templates. It'll all be completely done at the end of the visit. It's really, truly amazing. It's alive and well, and over several hundred physicians now, and continues to grow, delivered through this innovative cloud and secure technology that I discussed earlier. Next slide, please. Here's a quick orthopedist who's discussing DAX. You can read this, but what I'd really like to focus on here is, in a very short amount of time, what he's saying here is, we pivoted quickly to deliver the best patient care possible in this new virtual world. Technology like this is life-changing, and we've heard this over and over from our physicians. And the satisfaction that they're able now to do what they are trained to do, which is focus on the patient. And the technology is done so that the note is done the first time right. It's this ability to see the patient, take care of all their needs, and when they're done, the note is completely transcribed for them already and placed in the electronic health record. Next slide, please. So there are numerous strategies to improve telehealth efficiency. You heard several of them from Bob and Jim, but it's at its core, it's identifying the top needs, getting them prepared, whether it's in templates or in this technology platform, using your voice to command the computer, whether it's hotkeys that are run by voice, commands that do things in the emergency room or in a visit, show me the x-ray, do the orders and send it to the pharmacy for me. Using mobile tools like phones, like iPads, using it to capture images and video as well. I can tell the phone to do that or do it from a touch of a button. And then ultimately this completely ambient clinical intelligence where the physician is now almost completely free from the keyboard, not turning their back to look at the computer to type, but being face-to-face with the physician through the entire encounter and being complete and done at the end of that encounter. Thank you for your time.
Wonderful. Thank you all so much for those phenomenal presentations. We'll now launch into our panel Q&A. Audience, if you have questions, please continue to send them in. During our panel, we'll be sharing important news and statistics from our newsroom on your screen. So this first question I would love to address to all of you, and we can start with Bob and go down the line to Jim and Dr. Budman, but we talk about health inequities and disparities interchangeably. However, we all realize that in reality there are differences between the two. So in your own words, can you just briefly explain the difference between health disparities and health inequities in relation to your organizations?
Sure. You know, when we at ARP talk about the disparities versus the inequities, the disparities would be more just, you know, the observed differences that you can see based on maybe, you know, race, gender, socioeconomic status, geographic locations we're talking about here. Whereas the inequities, we look at those as more of the systemic, I guess, issues that really are contributing to that. In some ways, you could say there may be an injustice there. And so, you know, we talk about the telehealth and certainly, you know, the expansion of telehealth is great, but not everyone has access to that. But when we look at the investment to make that happen, there may be inequities in that investment. And I think more from a current headline standpoint, you look at, for example, the Navajo Nation, where you've got definitely the differences in the underlying health conditions of that population. And we've seen that really popped in terms of COVID. The rates in the population were much higher, but you can look at the inequity side of that, which says that, you know, there's probably decades of lack of investment that has really contributed to that, in some cases leading to lack of running water. So that's how we look at it at ARP.
Great.
Great.
Sorry, you want to go ahead?
Go ahead, Jim. Thank you.
Thank you. You know, I don't want to attribute this quote to my own thought because I read it somewhere, but I thought it said it well. It said, disparity implies a difference of some kind, where inequity implies an unfairness or an injustice. And I think, Bob, you touched on that a little bit. But, you know, an example that touched our organization is we're working with a rural hospital in Wichita Falls, Texas. And part of the current reimbursement structure for not-for-profit hospitals, they have to do what are called community health needs assessments. That's a requirement that they have to do to maintain their not-for-profit status, and they have to do it every 3 years. In that assessment with that particular hospital in that particular market, they discovered that they had food deserts. There were counties that did not have the ability to go to a local store and buy healthy food options. You know, so the hospital went out and formed a partnership with the local food bank, and the hospital at its expense started having food truck deliveries out to the areas where people could come in and buy or many times give healthy food options. But again, that goes back to is it the organization's responsibility? Sometimes people say, well, that's not a hospital's responsibility, but really any way we can help is where we need to be helping. So it goes back to the fact that you've got a county, an entire area that doesn't have the ability to have healthy food options. That will impact their health. So if we can find ways to go out there and fill that void, then I think that's a great use of our approach and resources to focus on the disparity and the inequities.
And for us, it's multifold because we are doing things as a vendor of technology, but also there as a partnership with our clients and our customer base. We very much cater to the smallest practices as well as enormous IDNs, and we try to be as flexible as possible. The fact that it's cloud-based makes us able to have that flexibility. And during the COVID-19 crisis, we announced giving away free options for Dragon Medical One speech recognition so that these small practices could very quickly become more efficient. So we're very mindful of the disparity and inequities in the marketplace, and we've tried to adapt quickly to that.
Thank you all so much. Dr. Budman, I'd love to stay with you for this next question. Do you have some key strategies when it comes to avoiding physician burnout in rural health settings?
Absolutely. You know, we've all heard about it, read about it numerous times the last couple of years. You know, it's the EHR. Well, there's multiple factors. It's not just the EHR. There's administrative burdens and so many other things that go into physician burnout. And what we've tried to do is to look at things like optimization, which in itself has a wide-ranging definition and principles that go into what optimization means. And a key strategy for us has been excuse me, well, get my thoughts straight here a minute, has been to give this voice-enabled documentation and voice control of the EHR to eliminate as much burden as possible. And that's where we've tried to eliminate what this discussion is of burnout, as I mentioned, with the self-writing documentation.
Fantastic. Thank you so much. And Bob, this question is coming for you. What are ways that family caregivers can be better integrated into the healthcare system?
Sure. I know touched on that really briefly, but maybe to give some specifics. You know, the looking at it is in terms of, you know, when that family caregiver is actually present in the rural hospital. You know, find ways that we've seen that hospitals have been very creative or been able to bring folks in is, you know, they make a note in the medical record that, okay, this is Mary's daughter, who is the primary family caregiver, is the person that we need to be contacting and connecting with. And then having a proactive way to provide information at that point of discharge. And that's going to help both the caregiver and the hospital. The caregiver is going to be much more prepared. They're going to know the things that they need to do. And it doesn't have to, you know, it could be just a real simple, let me show you what you need to do, let me give you some information. Maybe, you know, let's watch a video here in the hospital. It's also going to help the hospital because we've talked to family caregivers who say, you know, I didn't get that, and so I kept going back and making them show me what to do, and you know, so it's going to save time in the long run. And I think there are some cultural ways to do it. Something that we've seen that has worked for hospitals is they try to make the whole facility aware of family caregivers and their role. And so we do things from, you know, one hospital out in California we worked with, they gave all the family caregivers when they came in a red plastic folder that designated that they were a family caregiver. Another one in New York State, they actually created little badges for the family caregivers. And so it just really, it elevated that position within the facility, not a lot of cost to it, but also then culturally really said that, you know, these are folks that we want to be able to include and be more inclusive in terms of, you know, asking how they're doing, asking them what they're seeing with the patient to really make patient care a little bit better. And those are some of the easy things that we've seen, you know, really not a lot of cost that's involved in that.
Thank you so much. What a great answer. Jim, this next question is for you. Your organization manages a lot of rural hospitals and has an extensive knowledge of best practices. What can hospitals as a whole do to improve the health of rural Americans? And what are some best practices that you can share on how to manage and run a successful rural hospital?
I'll start with an example. About 2 years ago, we took over operation of a hospital in Gainesville, Texas. The year before we took over, the hospital lost $7 million. You know, this year it will make probably close to $3 million. It's not a matter of, oh, they're making a lot of money. It's a matter that they're sustaining themselves. You know, when you're in the negative, it's hard to make sure you're making payroll, maintaining bond covenants, all of those other issues that are essential to be able to make sure you're still there to provide care. So in order to get to the place where you're not losing money, you're positively cash flowing, you're positioned for the ebbs and flows of reimbursement challenges, The basics are making sure that the revenue that you're receiving for the services you're providing is being fairly compensated for. Tools like Nuance provide are a good example of, proper documentation. Make sure that you get proper billing with proper case mix index and get paid appropriately for what you're doing. Having good tools in place and processes in place to make sure that you document everything you need to document from a coding perspective, to make sure that you're going to be properly paid. But again, many organizations, especially in the rural markets, do not get paid fairly for the services that they're providing. It's not a matter of did they do the service, it's a matter of did they document it properly to get properly paid. The other side of that equation is expense. We've gone into critical access hospitals and taken over where they've had 400 employees. Well, a critical access hospital has got to be 26 beds or less, so a 26-bed hospital with 400 employees, there's an expense problem there. And that goes into that same category. You've got to be able to make the hard decisions, and you got to be able to make them before it gets you into a spot that you are in financial trouble and not able to continue to operate. Because if you continue to operate at a level that you can't sustain, then everyone's suffering. And then on the quality side, or the provision of care side, kind of goes back to the community health needs assessment. We do those with all of our hospitals, and we do them regularly to see where we believe the community is having a gap. Maybe it's mental health services. Maybe it's things like a food desert. Maybe it's things like the educational system doesn't have some of the tools that it needs. So make sure that you are working with your community, building relationships with your community, so your community sees your hospital as an essential tool to helping maintain the health and welfare of the community, not just another business, because rural hospitals aren't just another business. They're part of the lifeblood of that rural hospital and that rural community, to being able to meet the needs of the community.
Fantastic answer. Thank you. And I kind of want to piggyback off of your answer here. This question is coming from the audience, but how does the dynamics with the municipal and district ownership impact how you address turning around a struggling rural hospital?
So on that front, we've taken hospitals out of bankruptcy, and when we take them out of bankruptcy, we're not typically doing that as a standalone entity. We're doing it in a partnership with the municipality. So that district, but that voted in elective taxing district, wants that that district exists to make sure that care is provided for their community. So we form a separate entity, and that separate entity has a dual partnership. In that dual partnership, that's ownership structure of that new entity has us as one of the members, and it has the district as one of the members, or the municipality as one of the members. And there's reserve powers to make sure you keep everything legal and no one has any concerns about how things are working. But it allows a true partnership with two organizations that have the same mission. We're there to make sure that community keeps its hospital. That district was formed to make sure that there are resources able to provide care and services in that community. We just try to make sure that it's done in the most efficient manner and deliver as much care as possible. But the short answer is it is a legal entity that's formed in partnership with that municipality, and that new entity is actually what owns or operates the facility.
Thank you so much for that well-rounded answer. Dr. Budman, I'd love to move over to you for this next question. When it comes to implementing sophisticated technology like cloud-based solutions in a rural setting, what have you learned from your experience, and what should leaders consider from an infrastructure perspective?
Let me add one thing quickly to what Jim said, because it reminded me. He mentioned about capturing the right revenue for the acuity of the patients and documentation improvement. Is our Dragon Medical One platform has artificial intelligence solutions that plug into it and work with it to make sure that you don't miss diagnostic specificity, to make sure you capture those major comorbid conditions so that the CMI, DRG payment, and so on is fully captured. But to answer your question directly, our major advantage probably is this technology light deployment, which means the ability to remotely host and send out that highest value technology via the cloud to those rural hospitals. There's no servers to manage. You don't have to worry about a help desk. It shifts to the vendor. There's fewer employees needed to support. It's highly reliable, uptime wise, and no longer should we hear about CIOs or IT or CEOs being leery of the cloud. The cloud is strong now, and it is a great way to make sure that through my experience that in terms of infrastructure, that you're getting the best technology available.
Wonderful, thank you. And Bob, I would love to get your take on this question. What is unique about caring for older adults in rural communities, and what role do the family caregivers play in the overall patient experience?
Sure. I think we've touched on a lot of the unique aspects through the conversation. I mean, certainly you've got the distances just in terms of where people live relative to their care, to each other, the available services, the coordination. That really make it more challenging as an individual, as I think it was Jim who maybe mentioned earlier, just even the ability to get that to the hospital if you don't have someone who can drive you. So, what we've seen is, from an integration standpoint, those family caregivers are going to be the glue. They're going to be the ones who are going to make sure that the older adult gets to the local hospital, but also then gets to the specialty care that is often going to be several hours away, and then being that glue to be able to connect the dots so that what's happening in if your loved one is going for specialty care in Des Moines, but you're in northern Iowa, making sure that all the pieces are connected, and so certainly that coordination, the other thing that I think makes it a little unique is the employment situation for family caregivers can be very challenging, and so that's something that in a non-rural area you may be able to because of transportation, just take off lunchtime to be able to take mom to the doctor. You're not going to have that ability in a rural area, and the types of jobs and the infrastructure that exists might mean that from an employment standpoint, you don't have the luxury of, for example, right now working from home. You've got to be there in the store, an agricultural job to do your work, and so there's less flexibility there as well. So I think the one thing though that I would say is a positive is there's definitely within rural areas, when we talk to family caregivers, there's that community that you don't see in the non-rural areas. And so while things may be a little bit more that the longer distances, the things that you need, you've got the ability to ask for help from the neighbors, and that's really something we don't see in other communities. So really tapping into that. But it really comes down to the distances and the available services not being there, the lack of coordination that just make it challenging for the patient and for the family caregiver to have to play that role as the glue.
Excellent. Thank you so much. This next question I would love to address to all of you and get your insights and experiences on it. But we know that telehealth adoption has grown rapidly because of COVID-19, and it shows really no chance of subsiding. So organizations that are positioned to provide high quality care will thrive in this new normal. How are you and your partners approaching the lack of high-speed internet, Wi-Fi, and optimal cell service in remote areas of the U.S.? And Bob, we can just stick with you and move down the line again.
Sure. This is definitely one of the areas we've seen a lot. I mean, Jim mentioned it, and certainly Dr. Budman with the promise of telehealth, and it's really worked. And we've seen across the country that I think acceleration of technology has leapt forward by 5 years, but that doesn't always happen in the rural communities. And so the things that we're doing from an organizational standpoint, number one, even if you have the broadband, there's still going to be, for the older adults, the lack of knowledge on how to use that. So we've been investing in just simple consumer education as to here's the promise of broadband, and we've held national town halls where we bring experts in who talk about that. But then there's a part of ARP I haven't talked a lot about, which is our advocacy. And that's the really key, trying to drive to increase the telehealth presence around the country, looking for things that, maybe it involves legislative activity, but it also may be trying to get best practices for communities to look at ways they can bring telehealth to it. And, there's certainly a lot of promise. Just within the last couple of weeks, we were looking at it, and there are, I think, 6 new bills in the House and Senate that get at expanding the funding for broadband or accelerating the implementation of broadband. So, those are the key ways we look at it, but also I think some promise that comes out of all of this.
Great, thank you. Jim, do you have anything you'd like to add here?
Sure. There's a couple of things specifically to the broadband access, having the ability to have some of those tools in the rural market. There's a federal funding program called USAC. We work with a lot of hospitals to, actually, I think we're probably the largest organization that helps rural hospitals get USAC in the country. And that gets them reimbursement for spending the dollars on those type of technology, the ability to have the tools and their broadband capabilities. So a USAC program is an essential program to helping people get to that space. Also, just in this last reimbursement wave and under the CARES Act funding, I think there was $200 million that was focused on providing telemedicine dollars for expanding those services. But if you look at where that money's gone, the vast majority of it has not gone to the rural areas. So again, you have to go back and say, what are we going to do to focus on making sure that these places can get up to speed? So the metropolitan areas, they're going to have those tools that are going to be the backbone of the success of the program. I think Robert spoke earlier about people used to have fear of the cloud. The cloud today is not the cloud of yesterday, but the technology of today is not the same technology. But guess what? In rural areas it is, because that technology hasn't been updated. But in order to get it updated, and you're spending money on a telecommunication tool, or you're spending money on new surgical equipment, guess what? Always goes toward the clinical, which I'm not saying it shouldn't, but again, it has to have that backbone infrastructure to be able to get there. So the programs like the federal program for USAC funding is essential to try to get dollars out to those rural communities. I'll move forward.
Great.
And what I would add is, in the rural setting, is we work very closely with them on their technology to make sure it's sound and redundant. I actually worked at a rural hospital, and a fiber optic line thinner than my pinky got cut by a construction worker, and the hospital was down. So they didn't have a redundancy, a second line coming in from somewhere else, unprotected. It was just hanging. And I've seen wire rack server systems. So we work very closely to make sure that their technology is brought up to speed and safe, redundant, and has downtime backup.
Great, thank you. And Dr. Budman, I do want to finish us out with this one last question from the audience. We know how important telemedicine is in closing the gap in disparities and inequities. How do you provide access for limited and non-English speaking immigrant and some indigenous populations?
That is a great and challenging question. We do have speech recognition now coming up in multiple languages. We're in a few European countries now. But listen, with DACs, you could also patch in, as everybody now has generally access to, a third-party translation service that provides translations in literally dozens, if not hundreds of languages. You could bring them into a DAX, that's that Dragon Ambient experience telehealth visit, and it would be able to be translated and captured by adding in that extra person.
Excellent. Thank you so much. Unfortunately, I know we could talk about this forever, but that does take us to the top of the hour, and it's time to conclude this presentation. Thank you again to all of our panelists, Bob, Jim, and Robert, for your contributions today, and thank you to our audience for such great questions. To our audience, we value your time and feedback. Please take a moment to fill out our brief post-webinar survey so that we can provide the best content and resources for you. We'd love to thank our sponsors for today's webinar, AARP, Community Hospital Corporation, and Nuance. For more information about these organizations, please visit the websites listed on our screen. This webinar will be available on demand, and a copy of the slide deck and a link to the recording will be emailed to you within the next 48 hours. This concludes today's presentation. Have a great day, and thank you, everyone.
Thank you.
Thank you.
Yeah.